Hi everyone. This is a lecture on Chapter 6, Reproductive System Concerns, Student Learning Objectives, and these are identification of the cause of amenorrhea. You'll be able to contrast this menorrhea, premenstrual syndrome, and also to discuss the key points a nurse should consider in taking a sexual history. We'll also examine the risks and benefits of menopausal hormone therapy and describe the common signs and symptoms of perimenopause and menopause. Amenorrhea. Amenorrhea simply means no menstruation or absence of menses. So when you hear the term amenorrhea, it refers to no menstruation or absence of menses. And this is normal before puberty. So before a girl hits puberty, amenorrhea is considered to be normal. It is also normal during pregnancy and lactation and after menopause. There are two types of amenorrhea. We have what is called primary amenorrhea and secondary amenorrhea. And so the primary amenorrhea means that there is no menarche by age 16. And menarche is the onset of menstruation. So when a young girl starts to menstruate, that is called menarche. That first menstruation is considered to be menarche. So the primary amenorrhea means menstruation has not been established by age 16. So no menarche by age 16 despite having normal growth. And the most common cause of primary amenorrhea is Turner syndrome. And so this Turner syndrome, we will talk more about it when we cover genetic disorder. So that is the most common cause of primary amenorrhea. Other causes of primary amenorrhea include disorder known as Mullerian agenesis, and also the androgen insensitivity syndrome, which is a rare cause of these primary amenorrhea. We also have certain endocrine disorders that are responsible for causing primary amenorrhea. The next one is secondary amenorrhea. Well, secondary amenorrhea means that there is no menstrual bleeding for at least 3 menstrual cycles for females who had regular cycles. So now if you have a female with irregular cycles, it is considered to be secondary amenorrhea if there is 6 months of irregular or 6 months, no menstruation for 6 months for females who had irregular cycles. So for females who have regular cycles, if there is no menstrual bleeding for at least 3 months, it is considered as secondary amenorrhea. For those women who had irregular cycles, 6 months of no menstruation is considered as secondary amenorrhea. And so some of the causes of secondary amenorrhea includes pregnancy, and that makes sense. If you're pregnant, you don't see your period. There are also causes with regards to functional hypothalamic amenorrhea. And so this functional hypothalamic amenorrhea is due to weight loss. So when somebody loses excessive amount of loss, such as seen in anorexic patients or patients with anorexia, that could cause secondary amenorrhea. And nutritional deficiencies, strenuous exercises, emotional stress, those are some of the causes of secondary amenorrhea. And so how do you diagnose your patient with this amenorrhea? Well, thorough history and physical examination is needed. So you have to conduct a thorough history and examination on the patient. And of course, we'll do pregnancy tests to rule out pregnancy. Pelvic exam will be performed, and blood tests will be sent to see what is happening with the patient. So once again, the causes of amenorrhea include hypothalamic dysfunction. And so this hypothalamic dysfunction is one of the causes because menstruation and the menstrual cycle are controlled by the hypothalamus and the pituitary gland. So it makes sense that if there is a hypothalamic dysfunction, that could give rise to amenorrhea. And also it could be due to systemic stress, as I mentioned earlier, due to marked weight loss, pituitary dysfunction as a result of pituitary disease, tumor, change in hormones, low prolactin levels, and certain medications can cause amenorrhea. Chronic anovulation or ovarian failure is also another cause of amenorrhea. And remember earlier I mentioned Turner syndrome, and we're going to talk about Turner syndrome. And another cause is PCOS, which is polycystic ovarian syndrome. That is another cause, and we'll talk more about this polycystic ovarian syndrome later. Thyroid disorders are also causes of amenorrhea. Anatomic abnormalities, perhaps congenital absence of uterus, is also another cause of amenorrhea. Dysmenorrhea. What is dysmenorrhea? So anytime you see a word that starts with dys, it's usually difficulty, painful. So dysmenorrhea refers to painful menstruation. So the woman is having a menses or menstrual cycle, menstrual period, but it's painful. So painful menstruation is what dysmenorrhea means. And this dysmenorrhea occurs at onset of menstruation or the day before the menstruation starts, and usually it will disappear by the end of menses. There are also two types. We have primary and secondary dysmenorrhea. The primary dysmenorrhea, when a patient experiences primary dysmenorrhea, the patient will complain of cramps. So they have these cramps without underlying disease. Suddenly you start cramping, and this is caused by increased production of prostaglandins. It could also be due to ischemia caused by decreased uterine blood flow, and usually it disappears after first pregnancy. Some women do experience this primary dysmenorrhea, and I was one of them. I used to have this cramp so bad that I don't go to, even when I was much younger, I don't go to school the first day of my period, but I magically disappeared after my first baby. So if you have a patient with primary dysmenorrhea, something that you want to reassure them that it will eventually go away, and it would disappear. It will, disappear after their first pregnancy unless they're not having a baby. The secondary dysmenorrhea, on the other hand, occurs after menstruation established. So you've started menstruating, and then all of a sudden you start having pain. And so that has a pathology of reproductive tract. So that is what the second dysmenorrhea means. And some of the causes of secondary dysmenorrhea includes endometriosis. And so this endometriosis, we'll talk more about this endometriosis, but this is a condition where the endometrial cells grow outside the womb. So naturally, these tissues lines the uterus. So these tissues that normally lines the uterus, instead of being inside the uterus, they're now growing outside the uterus. So that is what that endometriosis refer to. And the most common symptom of endometriosis is pain. It is very painful. And also menstrual irregularities are also common symptoms. And so that endometriosis is one of the causes of secondary dysmenorrhea. A residual PID. PID refers to pelvic inflammatory disease. That is a cause of secondary dysmenorrhea, cervical stenosis, ovarian cyst, benign or malignant tumors, and presence of an IUD. An IUD, as we'll cover when we go over the lectures on contraceptives, you will learn about IUD is a method of contraception. And so the presence of an IUD is one of the causes of secondary dysmenorrhea. How do you treat primary dysmenorrhea? Well, the treatment of primary dysmenorrhea includes the use of oral contraceptives. So by using oral contraceptives, it inhibits ovulation. Or if you don't ovulate, or you don't menstruate. So that is the rationale behind using oral contraceptives. And also we use NSAIDs, which is non-steroidal anti-inflammatory drugs. So those are used in the treatment or the management of primary dysmenorrhea. There are certain self-care measures that could be implemented, such as the use of heat packs or warm compresses to relieve pain. regular exercise and rest, application of heat, good nutrition. Those are the things that you want to do when your patient, in order to help or to manage primary dysmenorrhea in your patient. The secondary dysmenorrhea's treatment includes continuous oral contraceptive therapy. And finally, the last resort will be a hysterectomy. And hysterectomy refers to the surgical removal of the uterus. So when the uterus is removed surgically, that is considered as a hysterectomy. Now let's take a look at premenstrual syndrome. This premenstrual syndrome is experienced by 20 to 40% of women, and this is usually during the luteal phase of menstrual cycle. It has some affective or somatic symptoms. The symptoms vary according to, it varies from one patient to another, and usually this premenstrual syndrome occurs after ovulation. It occurs before menses and occurs also in 3 consecutive menstrual cycles. So when women are, PMSing, sometimes they get irritated. You don't even want to be around that person. So if the person is having that, just, understand, know that is something that they have no control over, and, until it's over. Let's go back to that endometriosis that I mentioned earlier. This is the presence and growth of the endometrial tissue outside of the uterus. And the overall incidence of this endometriosis is about 5% to 15% in reproductive age women. And you see it a lot in women who are infertile. It's about 30 to 45%. And then in women with chronic pelvic pain, about 33%. So like I mentioned earlier, the major symptom is dysmenorrhea. These women will have painful menstruation, and they will have what is called dyspareunia. And this deep pelvic painful intercourse they will experience that anytime they're having sex. So they will explain, they will tell you how that they're having this painful intercourse, and that is known as dyspareunia. And the management of endometriosis is pretty much the use of drug therapy, and of course surgical intervention in worst case scenarios. There are associated menstrual conditions that you want to remember, such as oligomenorrhea, and this is usually when there is interval of greater than 40 days of menses. Oligo means few, so you're not having, you're kind of having scan period. We also have hypomenorrhea, and it's a short duration. Your period just came out in one day, and then the second day is done. Normally, your menstrual period is supposed to last at least 3 to 4 days, or in some cases 5. So when the woman has a short duration of period or menstruation is considered as hypomenorrhea. Hypermenorrhea, long heavy flow, and of course we have polymenorrhea when the interval is less than 22 days. Menorrhagia is a normal amount with irregular intervals. And then we have menorrhagia, which is excessive in amount and duration, regular intervals. Dysfunctional uterine bleeding, when a woman is having irregular bleeding between cycles, and it is due to if there is a dysfunctional uterine bleeding. Menopause. What is menopause? Well, menopause is the opposite of menarche. This is the permanent end of menstruation. This menopause is usually a turning point in a woman's life. It's not a disease, but it can have a big impact on a woman's well-being. So when a woman gets into menopause, there are symptoms that she will complain of. And these symptoms include hot flashes. Hot flashes is the most common one. You see some women, even in the middle of winter, they feel like stripping. So that is menopause. Hot flashes is very common. Night sweats. So due to this hormonal imbalance, irritability, vaginal dryness. So if a woman is going through menopause and she's still sexually active, well, you could tell her to use a water-soluble lubricant if she wants to have sex in order to avoid the vaginal dryness. There are other symptoms, and it varies from one person to another. Some women may complain of bloating. They eat a lot of food, they feel like their abdomen is about to burst. So it varies. So once again, menopause is absence of menstruation for 1 full year. The age of onset is usually by some women get into menopause around in their late 50s, early 50s, late or early 60s. So it all depends. It's influenced by overall health and genetic factors, weight and nutrition, lifestyle and culture. And sometimes they say if you started early, you might end early. So if you had early menarche, you possibly go into early menopause. But these are the most important things that affect the onset: overall health and genetic factors, weight and nutrition, lifestyle and culture. And of course, we have perimenopause. And this perimenopause is a period prior to cessation of menses. It can last anywhere from 2 to 8 years. And so during perimenopause, which can include the 10 years prior to menopause, it's still possible to get pregnant. Have you heard about women who get pregnant in their early 50s and they say this is the oops baby or the accident baby? Well, because they were having perimenopause, you saw your period, this period, and you didn't see it again. And then sometimes they just get pregnant accidentally, so to speak. So it's like the oops baby. So a woman's childbearing years are winding down during this period, and although her periods may become more unpredictable, her ovaries are still functioning. She may still ovulate, not necessarily on a monthly basis, but maybe, you could skip a month or two and then she gets ovulation, and the next thing that will follow is what? If she's sexually active, you get pregnant during ovulation. A pregnancy during this period may be referred to as a change of life baby, that oops baby. And periods may get shorter or longer during this perimenopause or going into menopause. It gets heavier or lighter with more or less time between periods. And then, you just have to reassure the woman that such changes are normal. There's nothing she can do about it. It's very normal. She has to get on with the flow. So this period of menopause is an opportunity to guard against major heart risks like heart disease and osteoporosis. It is very important that the woman guards herself against major health risk. When a woman is ovulating and menstruating, it actually prevents us from getting these heart attacks. But once a woman hits menopause, her chances of getting a heart attack now becomes the same with a man. So we really need to, educate our patients as they get through this period that they have to be careful. They have to do lifestyle changes. They need to do so. There are other causes of early menopause, and such early menopause could come as a result of oophorectomy. So bilateral oophorectomy, which is the surgical removal of ovaries, can cause a woman to enter into early menopause. Hysterectomy can also cause a woman to get into early menopause as a result of loss of period only. So this woman may start to see those symptoms that we mentioned that are associated with menopause. Chemotherapy is also another cause of early menopause. Pelvic radiation therapy is another cause of early menopause as well. Now, certain surgeries and medical treatments can induce early menopause, as we just mentioned. And so when you have that removal of ovaries, hysterectomy without removing the ovaries does not lead to menopause, although you will not have periods anymore. So if you have a hysterectomy and the ovaries were removed, then everything is completely removed. So then that person will not have a period. So if you have a hysterectomy, your uterus is removed. Only that, without removing the ovaries, will not lead to menopause. So if you have the surgical removal of your uterus, which is hysterectomy and oophorectomy, that will lead to menopause. And so with menopause comes a greater chance of heart disease, which is the #1 cause of death for United States women. So the #1 cause of death, or the leading cause among women, is heart disease and also osteoporosis. And osteoporosis is the thinning of the bones. Loss of estrogen may play a role for heart disease after menopause. So this is the reason why once a woman is in the menopausal period, we start them on estrogen replacement therapy if they are the right candidates. So once again, heart disease is the #1 cause of death for United States women, followed by osteoporosis. There's a picture. This is what happens with that thinning of the bones in osteoporosis. So what are the prevention and treatment of osteoporosis? Well, prevention is the primary goal. So you want to prevent it. And how do you prevent osteoporosis? Well, you want to teach the patients to maintain adequate calcium intake, or they need to take vitamin D supplementation. Estrogen also is effective in preventing osteoporosis. So this is why if a woman is menopausal, we'll start them on estrogen replacement therapy if there is no contraindication, because it is effective in preventing osteoporosis. There are significant risks for older adults. We do what is called the bone mineral density test. So the bone mineral density testing guideline is recommended for folks who are older. We do a DEXA scan. So this DEXA scan measures bone density at hip, lumbar spine. So pretty much checking the patient who is at risk for developing osteoporosis. These are the medical therapy, menopausal hormone therapy. These include hormone replacement therapy, estrogen therapy, progesterone therapy. However, the estrogen therapy is never given alone to women with uterus. So if you have a uterus, they have to give you a combination of other therapies unless you don't have a uterus anymore. There are risks associated with hormone replacement therapy, a risk for certain cancers. So we have to be careful with the patients before they go on this therapy. We have to make sure that some of these cancers, ovarian cancers and breast cancers, do not run in their family, or they are not candidates for that. There are benefits of hormone replacement therapy, and these are the recommended screenings for women at average risk for most diseases. General health, they need to go for thyroid testing, HIV test. Annually, you need to get an annual HIV test. They need to check their heart, make sure that it's healthy. Blood pressure screening, checking the cholesterol level. Also checking the health of the bone by doing the DEXA scan. Diabetes screening, breast. Every woman, once you hit the age of 40, from age 40, a gift you need to give to yourself is annual mammogram. Mammogram is a way of screening for breast cancer. So every woman from the age of 40 needs to go for mammogram every year. Now, if breast cancer runs in your family, you don't have to wait for 40 years. You have to be seen earlier than 40. But that is one of the recommended screenings for women, to go for mammogram every year once they hit 40 years. Every woman needs to do what is called breast self-examination. So breast self-examination is done every month. The best time to do your breast self-examination is a week after your menstruation. So anywhere from 5 to 7 days after your menses, you need to do your breast self-examination. How do you do a breast self-examination? Well, you could do it while you're standing up in a shower, taking a shower. With your hand, you put your hand towards the back of your head, and in a circular motion, you checking for lumps on your breast. Check it. You could do it in a supine position. You go in that circular motion looking to see if you will feel any lump. Now, if you find any lump, you have to let your doctor know. While you're doing this screening, this breast self-examination, it's very important to remember to include the tail of Spence, because higher incidences of breast cancer actually start from the tail of Spence. So you have to make sure that under the armpit that you include that area. That is what is called the tail of Spence as you're doing that. Remember, the breast self-exam has to be done 5 to 7 days after your period. You don't do it before your period, because before your period, everything is so lumpy. You feel so sore and tender. You don't want anybody to touch you before your period. So you do it after your period, 5 to 7 days after, and mammogram is done annually from the age of 40 up. You also want to teach your patient about pap smear. They need to go to their gynecologist and do pap smear testing. Actually, the current recommendation for pap smears is every 3 years for women, at least from the age of 21. If you're sexually active, you have to be screened for pap smear because of the relationship between that and cervical dysplasia or cervical cancers. So that is one of the things you want to recommend for your patient. Of course, they need mental health screening, checking for depression and all the rest. Colorectal health is also assessed or screened. They have to do colonoscopy. I think colonoscopy from the age of 50, you get colonoscopy done unless you have history of cancer in your family. Eye, ear, skin, oral health, all those things have to be screened. They need to go to the doctor, the eye doctor. At least as we get older, we need to see the ophthalmologist to check the eyes. We want to rule out cataracts, rule out glaucoma or dislocated lens. Oral health, see the dentist from time to time. So these are all recommended screenings for women at average risk for health for most diseases. These are your recommended immunizations: influenza vaccine, pneumococcal vaccine, tetanus diphtheria booster, HPV vaccine. They give it to kids now, I think from the age of 11. They start giving it to them. Meningococcal vaccine, herpes zoster vaccine. So now if your patient is pregnant, definitely they could get a flu shot. They could get DTaP, but not any other vaccine. They cannot get any live vaccines during pregnancy, and we'll talk more about that as we go through. I think it's in the next couple of lectures we're going to cover that. Prevention of coronary heart disease, that all starts with lifestyle modification and changes. So the patient needs to make some changes as they get older. You want to be familiar with signs of myocardial infarction in women, as most times it presents differently in women than it does in men. Chest pain is a concern. If there is pain in arm, back, neck, or jaw, they need to be seen immediately. If the patient is complaining of stomach pain, sometimes women feel like they're having heartburn and not knowing they're having a freaking angina. So if your patient is complaining of that heartburn, she needs to be seen immediately. If she is an older woman, that could be a sign of heart attack. Shortness of breath, nausea, lightheadedness, sweating, fatigue, those signs should not be ignored. The health risks to women, there are social, cultural, economic, and genetic factors that attributes to this. Diabetes, or that will be if it runs in the family, will be a risk. Overweight, obesity. Remember the let's move. Exercising is very, very important. You teach your patient, every woman, everybody, exercise is good unless there is a problem with the patient. So you just have to assess the patient. What kind of exercise can they do? Overweight, too much weight is not good. It leads to cardiovascular problems. So you want to maintain ideal weight. Hypertension is also another health risk. Substance use and abuse, smoking. If a patient is smoking, you have to encourage them to quit smoking because of all the issues that could come along with that. Alcohol consumption, Now, alcohol, I mean, unless they are pregnant, they need to stop. They cannot drink alcohol during pregnancy. But if a patient is consuming alcohol, well, moderation is the key. They need to be very mindful of how much they drink. You don't want to drink to intoxication. If there is a health risk, they need to stop it anyway. Caffeine, prescription drug use, illicit drugs, all those things are health risks to women. Now, there is a question here. A woman complains of severe abdominal and pelvic pain around the time of menstruation that has gotten worse over the past 5 years. She also complains of pain during intercourse and has tried unsuccessfully to get pregnant for the past 18 months. These symptoms are most likely related to, well, I hope if you see this question, you are guessing endometriosis. Well, that is the correct answer. Endometriosis is the culprit. That is the reason why this woman is having the dyspareunia and being unsuccessful in getting pregnant. And this